can you make me look like Angelina Jolie? If it's just one size fits all, it's not a balloon that we're filling. No tan is healthy. Sitting in the sun, burning, and it scares me when I see a sunburn.
Do you also have this kind of syndrome? Do you catch yourself staring at people's faces?
And where I come from, in Lebanon, everyone looks the same. And I view the face as my canvas. See a spot change, see a dermatologist. He can or she can put the patient on a 2-week wait scheme compared to a year wait for things like psoriasis. The patient gets seen by a dermatologist within 2 weeks.
I never knew that it's super, super important until I heard a dermatologist in a really nice podcast saying, use your sunscreen. Hi, I'm Hala, your host today. We'd love your support. A quick subscribe to this channel would mean a lot to us and help us grow. We may be small now, but with your support, we can achieve something amazing together. Thank you. Welcome to the Visionary Podcast, where we discuss science, medicine, physical health, and mental well-being. I was born and grew in Egypt, and I spent a lifetime in Egypt under the frying sun for days and days, never used sunscreen. I guess that's bad now, but I've only started using sunscreen in the last 3 or 4 years because I never had that education. I never knew that it's super, super important until I heard a dermatologist in a really nice podcast saying, use your sunscreen. So that's when I started. Let's move to skin conditions, please. I think we all get some sort of spots or hyperpigmentation. Let's say pigmentation. I have a little bit of ones here, and I think nothing of them. From what I understand, they don't usually need any medical intervention. But what should I be looking out for in my skin that might indicate that there's something ominous happening here with these spots?
So there's a slogan, I think it comes from the American Academy of Dermatology, which I'm also a member of. It says, see a spot change, see a dermatologist. So basically skin cancer comes in different forms and colors and shapes. But a skin cancer spot can be a red spot, can be a brown spot, a black spot, can be a mole that has changed and evolved and grew. It can be a brown or a mole that suddenly becomes irregular, has asymmetry, different colors. It's more like skin cancer or like ominous skin spots. Statistically speaking, are more common in elderly people, like middle age and older elderly people, and they're more common in people with fair skins, like skin type 1, 2, 3. So basically anything, a spot or a rough spot that won't go away, you apply moisturizer or a cortisone cream and it's still there, starts growing, go see a dermatologist or go to your GP, and then if he or she suspects, they will refer you.
Okay, so if it changes color, if it changes size, if it changes texture, I'll speak to someone.
Yeah. Okay. If you're not sure what it is it something hard or a lump that is growing? Basically, if you're not sure, ask a doctor.
You did mention loads and loads of factors and variables that we mortals wouldn't be able to decipher them. I find skin conditions very, very mysterious things. I once had something, I actually practiced pronouncing them, but if you could please help me. This.
Rosacea?
Rosacea.
Yeah.
I had that once. I think I was 24. It started with a patch in my back, and all of a sudden...
rosacea. Sorry, not rosacea. This is different.
Oh, God.
Pityriasis is rosacea.
Rosacea. Yes. Okay, yeah. But there is a name before that. It started as a patch in my back, and it spread like a horror movie all over my back. It was the most... horrific rash. And I've seen my dermatologist, he passed away back in Egypt now, but he said to me, don't worry about it. It's going to go away. That's exactly what happened. It was like a slap on the face.
Yes.
Thankfully, it wasn't painful, but it looked like I couldn't have imagined that this will disappear in 3 weeks. And it did.
It does.
Amazing. And I was told it's a once in a life condition. Once you get immunity, and it goes away. Another thing I have is a birthmark. My cousin has exact the same. He's a male, has exactly the same birthmark in the back on the same spot, the same shape, same size. Should we worry about birthmarks?
It depends what birthmarks they are. So we're talking about brown birthmarks, not red birthmarks. Red birthmarks, everyone knows they are not cancerous, like vascular birthmarks. Brown birthmarks can be completely benign and never change into skin cancer. For example, things like cafe au lait macules, which are brownish stains, and they are birthmarks. They can be on the face, on the body, and these never change into skin cancer. Nowadays, we use an instrument called a dermatoscope, as dermatologists, which wasn't there when I studied dermatology and started practicing, but for the last, let's say, 15 years, it's become something of a tool that we need to use. So it's like a skin microscope where we would look and it would magnify the cells and the structures in the skin, and it's science by itself. So there are some features that tell us and give us an indication on whether the birthmark or the mole or the brown spot is cancerous or not. But of course, you can't use it. Some GPs have learned how to use it, in a basic sense. But for you, for instance, you have a birthmark, a mole, a congenital mole on your back. Familiarize yourself with how it looks. And then maybe once in a while, every 6 months, something like that, take another picture or look in the mirror. If you see it changing, the rule, the old rule, is called the ABCDE rule. So A stands for asymmetry. The mole starts becoming asymmetrical. B stands for border, so an irregular border. So before it was like a really sharp border.
It's shaped as a like a grape kind of thing.
Even if it's shaped like a grape, if it hasn't changed, you shouldn't be worried. But if it starts changing in as symmetry, border, color, it was tan, and then you see specks of black in it or specks of white. Diameter, D stands for diameter. It was 6 millimeters and now it's 7, 8, or E, evolving. That's what I talked about. Then of course have it checked.
Yeah. I'm not thinking of stress. Let's say chronic stress, because nobody has zero stress in their lives. How can stress affect my skin negatively?
So certain diseases are flare up and are triggered by stress. Psoriasis is one, acne is one, rosacea is one, hair loss is another one. So in an indirect way, stress reduces our immunity and causes probably more inflammation, and that is how some eczema, even when kids or students pass through exam period, their eczema flares up and becomes worse. So this is, it can, yes, definitely stress can worsen some conditions.
Let's talk a little bit about hormones, our lovely female hormones. In teenage years, we get a huge surge of hormones followed by a kind of plateau till we get pregnant and have another surge of hormones, then another plateau, another pregnancy, till we reach perimenopause and menopause years. I want to know from you, how does my skin react to all these fluctuations of hormones?
So in the teenage years, as we talked, your acne surges and flares up. In pregnancy, you can get things like melasma or cloasma or the mask of pregnancy, which is the pigmentation on the face that can happen in some pregnant women. Perimenopause, menopause, you can get a few spots as well. You get dry skin, you get vaginal dryness, you get some hair loss because of the hormonal fluctuations in perimenopause and menopause, and hormone replacement in that period, HRT, in women who can take it or who get prescribed it, can negate these side effects.
We're having such a beautiful early spring here in the UK. Today is Good Friday, and soon enough it will be summer and we will go on holidays, fry under the sun. You already told me that it is not good for me and I do need to use sunscreen. I want to drill down on this a little bit. Why is sunburn bad for my skin, other than the obvious factor that it's painful?
Sunburn and unprotected sun exposure causes DNA damage, and DNA damage can predispose you to skin cancer later in life, and skin cancer can be deadly. Melanoma is deadly. And if we're not talking about aging, like the sunspots, the wrinkles, the laxity, this is all sun-induced. If you don't want to mention those, if you do not protect yourself and you get sunburns, you sharply increase your risk of skin cancer. And sun is the main cause of skin cancer. Of course, you can get melanoma in sun-protected areas, but it's mostly and melanoma can be hereditary. You can have genes for melanoma or basal cell carcinoma, but sun is the major factor. So by exposing yourself to unprotected sun exposure, and the fairer your skin is, the lighter your skin is, and the more burns you get, the more DNA damage, and the higher the rate of getting skin cancer when you are more mature.
Oh, so when you say more mature and when you say later in life, does this mean that in my 20s, if I fry myself, bake myself under the sun and get the sunburn, then I damage my DNA? Does this increase the risk of skin cancer 20 or 30 years later?
Yes, 100%. Yes. Okay. It increases your risk. It predisposes you to skin cancer. The more sunburns you do, the higher exponentially the risk of skin cancer that can happen. So I still get really anxious when I sometimes go to beachy areas and I see people up until now, 2025, sitting in the sun, burning, and it scares me when I see a sunburn. I almost feel like rushing to them, and of course that's not polite. I would never do it, but I almost feel like saying, please put on a t-shirt, please move away, please wear your sunscreen, because you are increasing your risk of skin cancer.
Okay. Now I'm wondering, why does skin cancer take such a long time to manifest itself? I'm just thinking how scientists could make that connection, the causation between the DNA damage in my 20s and skin cancer 20 or 30 years later.
It's a lot of scientific studies, causality, evidence-based medicine. Mutations happen, but then it takes years for that mutation to progress into skin cancer. It takes years, can take decades. So it's a lot of research, lots and lots and years and decades of research and centuries of research that have gone into proving that causality between sun exposure, DNA damage, and skin cancer. It's the same way that applies to smoking and lung cancer. So if you smoke 1 pack a day for a year, you're not going to get the lung cancer immediately. It's over time, this smoking which leads to lung cancer and heart disease. So it does take time.
Now, how do I choose the perfect sunscreen for myself? What should I look for on the package? Give us a complete guideline.
So SPF is the main thing. It's called sun protection factor. It's the number that you see on the package of the sunscreen. And it refers to the amount of time you can sit in the sun with your sunscreen before getting burned. So which means that sunscreens are not 100% protective. So let's say an SPF of 50 means that compared to sitting in the sun without any sunscreen, if you apply this sunscreen, you can stay for about 50 minutes before getting burned, but you will still get burned eventually. So the number you should be looking for is at least 30. Don't go for anything below 30. The standard, there are nowadays in most sunscreens, good medical grade sunscreens, is 50. But I would say at least 30. Anything less than 30 is not really protective enough, especially if you're going on holiday, beach, snow, and there's a lot of sun exposure. And then you should look at what does it protect from. So SPF refers to UVB, ultraviolet B, which causes most damage, DNA damage and skin cancer. But there's also ultraviolet A, UVA, and more recently, research has found that also visible light, blue light, infrared light can damage the skin. So ideally, look for something called broad spectrum sunscreen, which means it protects against UVA, UVB, and visible light. And the third thing is look at the texture of the sunscreen. If you have oily skin, go for a sunscreen that says for oily skin, does not clog pores. You can get a spray sunscreen. I like it a lot for children because then you can spray it on even when they're wiggly and jumping around. Lotions compared to creams. Tinted. The last thing would be if you have pigmentation and melasma, go for a mineral compared to a chemical sunscreen. So mineral sunscreens or physical sunscreens, and especially tinted ones that have a bit of makeup in them.
How would
a
I know
little
the
color.
difference between the mineral sunscreens?
It says on it.
It would say.
It would say physical or mineral sunscreen. So they're more protective. So people with sun allergies, sun sensitivity, photosensitivity rashes, or pigmentation, melasma, I would recommend mineral or physical sunscreens for them, or tinted sunscreens. Some sunscreens have color in them, like a bit of makeup, like what I have now. So it just gives a little glow, a little color.
So let's say I spend the whole day on the beach. Should I top off on my sunscreen every few hours?
Yes, absolutely. So sunscreen, if you're on the beach, make sure first of all to apply it 20 minutes before you go out in the sun. And then if you go out and you're swimming, even with your sunscreen, we always recommend wear a wide brimmed hat, avoid the sun at its peak, that's between 11 and 3, and reapply your sunscreen every 2 or 3 hours. Yes.
Okay. Should I cover my ears? I've always
Yes.
wondered about that. So all
Yes.
exposed areas.
Skin cancer can happen on the ears. It can be aggressive on the ears. Yes, ears. If men are bald or they have balding hair on the scalp as well, because they can get skin cancer on the scalp. Don't forget your hands, your chest, everywhere. Yes, your ears, your lips.
Lips.
Yes, your eyelids.
Yeah. Now I remember my nan, may she rest in peace. It was years and years ago, maybe 14 years ago. I was just a child when she refused to go to the beach with us because she was concerned about the sun. And that was at a time when we didn't even have sunscreens on the market. And my mom told her, you're going to be under the umbrella, you're going to be just fine. And she said no, because the rays bounce off the sand and hits her face. Was she right?
Absolutely. So you do get ultraviolet in the shade. You get it in cloudy, rainy days. Of course, you get more when you're in direct sun on the equator. Noon time, of course, that's its peak, but you can get burned. Your nan is right, you can get burned.
Wow.
If you're sitting under the umbrella, if you don't have sunscreen, the light gets reflected and it travels in to the shade and it can burn you. That's why people who ski get sunburned on their faces badly if they don't wear sunscreen, because the sun rays get reflected from the white snow. They hit them on the face and they can get badly burned. I had a friend once who told me her son got his eyes burned, his cornea was burned while skiing, actually because he wasn't wearing goggles. The intensity of the sun up in the mountains with the white snow burned his eyes. His cornea got damaged.
Wow. What about these UV protective swimwear or beachwear that supposedly shields the entire body from the sun? Are they effective?
Yes, they are very effective. They are very common in areas like Australia, where the rate of skin cancer is extremely high because they have like a deficiency in their ozone layer. So it's very common for people there to wear fully protective UV reflective swimwear, long sleeves, long pants, and to protect you from the sun. They are good to be, it's good for us to have our children, our babies, wear them.
Hearing you talking about children, I grew up in Egypt, and sunscreen wasn't a thing at that time. As I mentioned, nobody I knew used it. So I think I carried that negative legacy when I moved to the UK. I now have a 9-year-old child, and sometimes I remember, but I just ignore applying sunscreen on her. We're rushing hours. I think, oh, she's half Egyptian. She never burns. She's going to be fine. Am I doing her a disservice?
So the lighter the skin type, so Fitzpatrick skin types go from 1 to 6. 1 being the very fair skinned, blue eyes, blonde hair, and those are the people, skin type 1, who always burn but they never tan. And those have the highest risk of being burned and getting sun damage and skin cancer, all the way to skin type 6, which is black skin. And those are the people who never burn. So the lower the Fitzpatrick skin type, the higher the risk. And the higher is the lower the risk of skin cancer. So it's a spectrum, but everyone needs to wear sunscreen. Of course, black people, black skin, risk is very low. They have a lot of melanin naturally that protects them. So no, they don't really need to wear sunscreen. But the lower you go on the spectrum, yes, you do need to wear sunscreen all the time.
I should behave,
Yes.
really, and do my job as a mom. What about tan beds? They are super popular in cold countries like here in the UK. Are they a no-no or in moderation?
They are a no-no. They have been in multiple studies linked to skin cancer and skin aging. And for us, we say no, no, no. In some countries, they're even banned. Hopefully here in the UK there will be some kind of law that will ban them, because they're intense UV exposure multiple times. And yeah, they do have a risk of skin cancer. Of course, when I tell people like to tan, they like that glow, they think it's healthy. For us as dermatologists, we try to convince them that no tan is healthy. The fact that you've tanned means that you've had some kind of DNA damage. You have damaged your skin. But at least do it gradually. Do not burn. So at least, if you do want to tan, do it very gradually. Use your sunscreen. Get that tan very slowly. Don't just burn yourself and get blisters and peel. And that can happen with sunbeds as well.
So we eventually come back from holidays with a very ominous tan. What should I apply on my face to reduce the sun damage?
The only the mostly evidence-based thing that you can apply would be prescription tretinoin or retinol, which are vitamin A derivatives. Those creams can reverse to a certain degree the damage, but not fully. Like when you have a mutation, it has happened. But vitamin A derivatives applied on the skin can, sometimes we use them to treat some kinds of precancerous lesions, or they can reverse to a certain degree sun damage.
Okay. And you mentioned that these will need a prescription, right?
To higher percent, yes, you need a prescription.
Yeah. So you're telling us with very strong terms to avoid the sun and wear sunscreen, even in winter, even in the shade. I've read somewhere that sunscreens prevent my body from absorbing vitamin D. Is this correct?
So to get enough vitamin D, 10 to 15 minutes, maybe 20 minutes of direct sun exposure are enough per day. So you don't need to be sitting for hours and hours and burning and tanning in the sun to get vitamin D. And because here in the UK, we don't see the sun for several months, it's good to get a supplement, like take supplements, 1,000 units a day or 10,000 units a week of vitamin D during the winter periods. Sunscreen, if you apply sunscreen, doesn't prevent it 100% from vitamin D is made in your skin from sun exposure. So it does not prevent it completely, but of course it blunts it. So, but if you do want enough vitamin C, let's say you expose your legs to direct sun for 10 minutes a day, 15 minutes a day, that's it, you have your enough vitamin D. And of course, you can always get the supplements, and it's recommended. There are some diseases which benefit from the sun. So sometimes we do tell patients with psoriasis, go in the sun, sit in the sun. Of course, don't burn yourself, because ultraviolet and specifically UVB, UVA, PUVA is a treatment for psoriasis. That's called phototherapy. So sun can be beneficial for some skin diseases, and it can be harmful for a lot of other skin diseases. So if you have rosacea, you have lupus, you have to stay out of the sun.
Now, if I want to damage my skin, increase pigmentation, have the sagging and the dullness and all the rest of that, what would I do?
Smoke and sit in the sun.
Smoke. Yeah,
and sit in the sun,
Um,
unprotected. A lot of high intake of alcohol also can have some deleterious effects on the skin. So high alcohol consumption, the same way it affects other organs like the heart and the brain, it can also impact.
Am I correct in assuming that the sun is the main cause of skin cancer?
Yes, in all of them.
What about genetic factors?
Yes, they do play a role. Definitely, there are some genes that predispose you for melanoma and genetic variabilities, but a lot of the times they are also compounded with sun exposure. So if you're exposed to the sun unprotected and you do have that gene, your risk is higher. You do get melanoma in sun-protected areas as well. I'm not saying it does not happen, but it's more common in sun-exposed areas.
Yeah, talking about the areas that do not see the sun. If I have like a mole or skin irregularity, should my GP or dermatologist check my entire body?
If it's a melanoma, yes, any skin cancer. If we diagnose skin cancer, we do check the entire body, of course. And if you've been diagnosed with melanoma and your melanoma has been removed and so far has not spread, so based on the depth of the melanoma that is excised and removed, we have an algorithm to decide, and of course there are oncologists that get involved and surgeons.
I have some statistics here for you, please, though I'm sure you have more accurate ones. Skin cancer cases in the UK have been rising, with melanoma cases projected to reach around 20,800 in 2024. We're now in 2025, marking nearly a 30% increase over the past decade. Approximately 17,000 of these cases are considered preventable. I'm assuming preventable because we expose ourselves to the sun. Is this
Yes.
correct? Okay. Projections indicate that non-melanoma skin cancer rates may rise to reach 310 cases per 100,000 people annually. Why do you think we're seeing this rise in cases?
More people are getting exposed to the sun, and they're still unaware, but the mortality is dropping even though the cases are rising because of early detection, because of awareness, because the earlier the melanoma is removed, the smaller it is when it's caught, the higher the chances of cure or remission from that melanoma. GPs have a high rate of awareness about what is suspicious, what is not, and there's something called the 2-week wait in the NHS. So if a GP sees a spot and suspects a cancer, specifically a melanoma or a squamous cell carcinoma, which are aggressive, he can or she can put the patient on a 2-week wait scheme. That means compared to a year wait for things like psoriasis, the patient gets seen by a dermatologist within 2 weeks.
That's brilliant.
And then if a dermatologist in the hospital sees the lesion and confirms that it could be melanoma or squamous cell carcinoma, of course they cannot prove until they remove it. Then again, within 2 weeks, that lesion is removed.
On the mention of the NHS a few minutes ago, and the NHS is one of my favorite subjects. Dr. Injibar, you worked in the NHS as a locum consultant dermatologist from 2018 to 2022. How was that experience for you?
I loved working in the NHS. I really enjoyed it. It has its drawbacks, as in mostly there's not enough time given per patient because there's such a huge backlog, and I get given 10 minutes to see a patient. Many times this is not enough. So that was frustrating. But I think the NHS is an amazing system, and it's an amazing healthcare system. And although people complain a lot about it, and although, of course, there are improvements that can be done, but I did enjoy working in the NHS and being a locum dermatologist.
Yeah, I totally agree with you about the NHS. It's an amazing service. And I think I mentioned that zillions of times now on this podcast, that I have a list of diseases and conditions, and they are all under proper management. There is a hiccup here or there,
Yeah.
but I wouldn't really worry about that. But it's an organization totally worth saving and maintaining for the rest of
100%.
us. Dr. Injibar, we usually end our episodes with big picture kind of questions like visionary, moral, ethical, and I have lots and lots of them for you. Okay. Are there any new technologies in medical dermatology, not cosmetic, in medical dermatology that excite you, or you think they're going to be the future?
There are a lot, but if I want to mention one of them, me being a laser specialist and a laser surgeon, I always get excited about lasers. And there's a new, relatively new kind of technology in lasers, the 1726 nanometer laser, which treats acne without the need for medications and drugs and tablets.
So is this a new thing?
Relatively new. Yeah, it does not treat, it's not the scarring, like I do lasers to treat acne scars. That's different. These we have had for quite a long time now. But it's a new wavelength to treat active acne. So treating acne with lasers compared to tablets. So for those who cannot take tablets or medications, or it's something new, and it will improve, and it will progress, and eventually we'll have a better technology than the one that exists now, which is faster, more efficient. But that's something that's medical, blending medical and aesthetics.
Yeah. I read on your website that your approach emphasizes embracing the healing process. Could you please elaborate on this philosophy?
Yes. When patients or people finally come to me or reach my practice, they need results. They need to see results. They sometimes have been to other clinics and been treated by maybe beauty therapists, or done lasers, which have, or mild peels, which have barely touched the surface. Yes, you don't get downtime, but then you don't see dramatic results. I still do procedures that don't have downtime. Of course, I still do that, and I approach each patient differently, and I ask about their lifestyle, their work. But if they can embrace downtime, I like to do procedures that really work. For example, and also depends on the condition. They have melasma, pigmentation, sun damage. I like to do like deep peels, aggressive peels, or CO2 laser, which give the wow effect later. I hold their hand throughout the procedure, but then they see the results. For example, they have things we call xanthelasmas under the eyes, which are yellowish, lumpy things that are cholesterol deposits. Yes, I can erase them with lasers over and over and over, but I can excise it and cut it out and put stitches, and that's one-time thing. They might have a bruise or a blue eye for a week or a few days, but then that's it. It's done.
Yeah. So I hope I get this right. So I've been writing notes. So you're telling me that the current treatments favor short-term solutions, minimal downtime, and maybe regular treatments. But you do things in general the other way around, like long-term solutions, more downtime, and maybe fewer treatment sessions.
Yes.
Is that correct?
Yes.
Okay, so yeah. Also, part of your ethos, you talk about achieving subtle yet noticeable improvements. But what if you see a patient who wants dramatic transformation to the point of maybe being unrecognizable? How would you deal with that?
That this mostly relates to injectables and dermal fillers that might make them look different and unrecognizable, overfilled. Those I try to discourage as much as possible, and because my approach is subtle and maintains the natural look and implements and augments some features that might be natural in your case, but you don't like. For instance, very thin lips. You're born with very thin lips. You don't like them. They don't match your face. Of course, I can fill them to make them more voluminous and give you a nice pout, but I wouldn't overdo it. Of course, if you have flat cheeks, I would fill them, but I wouldn't overdo it to the point that you look fake or artificial. So I try to discourage my patients from overdoing this, not to look fake.
It must be a fine balance because I'm now wondering about the psychology of dermatologists. You guys must have like an urge to fix, repair, and perfect, these kind of things. So it must be a fine balance between having perfection and a natural look.
Absolutely, it's a fine balance, and we have to always remember as doctors that we swore an oath, which is the Hippocratic Oath, and I have it hung in my treatment room, and that is do no harm. And when you are even practicing aesthetics and cosmetics, it's still a medicine. It's an art and a medicine. And if you are doing aesthetic procedures, having in mind any like financial gain or following whims of the patients, then you're not really practicing good medicine, and you swore an oath to do proper medicine. So this all falls into this. And if some patients have a hidden agenda or a psychological problem that they're trying to fix by changing the shape of their noses or their eyes or their lips or their face. And we are trained as doctors to detect this and to not treat in this case, of
What
course.
would you tell them?
It's very delicate. It's a very delicate thing to do. Sometimes you might not succeed. Sometimes you might succeed in convincing them to talk to their GP, to refer them to a talking therapist. In my case, I would maybe do a little something that is not overboard, to give them a little satisfaction, but at the same time addressing their other issues. And sometimes just by talking to them, let them ventilate, talk about their problems, give them a mirror and try to convince them that, we don't need to do this. This looks fine.
Yeah. Dr. Injibar, you studied dermatology at the American University of Beirut, where everyone is so beautiful, incredibly beautiful. As they say, beauty is in the eye of the beholder. How do you see beauty? How would you define a flaw, for example?
I think everyone has a beauty naturally, but if you're someone who's bothered by the shape of your nose, the size of your lips, the way your face is sculpted, then I can help repair it and correct it. Beauty in general terms in aesthetics and cosmetic medicine is mostly defined as symmetry. So symmetry and having a third, and having symmetrical facial features is the general definition of beauty. That's why you see people like Angelina Jolie as being the standard of beauty, having a very symmetrical face and symmetrical features.
Yeah, I love beauty. I love looking at people's faces, and I love spotting beauty, even in people who are not conventionally beautiful. I always find something easy to look at. Do you also have this kind of syndrome? Do you catch yourself staring at people's faces?
Yes, of course, because that's how my eyes work and my brain works. But I find myself more focused on skin diseases, specifically acne. So when I see someone with acne and I see them hiding it behind layers of makeup, or I look at the skin and I see scars, that is what drives me. I feel like, I wish I can help that person. I wish I can tell him what to do and that they can seek help and improve it. Because I deal with correcting faces and flaws and skin at work all the time, I wouldn't necessarily focus on them a lot when I'm outside work. But yes, of course, I study faces and I study the skin. And in my mind, automatically, I make a treatment plan, even though we're just on the tube or, in the grocery store.
Yeah. I remember maybe 30 years ago when everyone who had, I'm assuming now, plastic surgery looked like Cher, the American singer, if you know her, was popping cheeks. How do you avoid making multiple copies of the same chin, same cheek, same nose?
By embracing the individuality of the look, by restoring the way that face looked when it was younger, rather than changing it drastically to someone who is not them, by looking at what suits them. For example, someone with really thin lips and a really small face would look unnatural if the lips are plumped aggressively and to a big degree. But unfortunately, and specifically in where I come from in Lebanon, everyone looks the same. So it has.
I found them really beautiful.
They are very
Like
beautiful.
flawless.
Yes, but
I was a peasant there.
Yes, but nowadays it's a lot of the same noses, the same cheeks, the same eyebrows, and the same lips, which I try to avoid in my practice.
How about taking ethnic uniqueness? I think you actually touched on that. I come from the Middle East slash North Africa because I was born in Egypt from Egyptian parents. Surely I have different facial features than a white British woman, different than an Asian woman from Hong Kong. So do you take into account that ethnic uniqueness?
Of course, that's what I mentioned before. I take into account the ethnic, I take into account their facial features when they were younger. So we're basically restoring and repairing rather than changing and overcorrecting. And also, I'm not a plastic surgeon. So plastic surgeons are the ones that cut and shape noses, and they lift faces, and they can do things like a lip flip and a lip lift. So when they're, or, breast augmentation and all of these things. And they can also fall into traps of making everyone look the same. So everyone has the same nose. So there also goes the importance of educating the patients that, this nose suits you. A smaller nose with your wide face and big cheekbones would look unnatural. So it's educating the patients and making sure you maintain their ethnicity and their features. For instance, Asian people, if they completely do a full blepharoplasty and remove their hooded lids completely, they will look strange. That's not their ethnicity. So yes, of course, you have to maintain.
I feel that beauty treatments or skin treatments are a blend of medicine and art. How much of it that you do in your clinic is something that you studied in medical school, and how much of it is due to or down to your artistic sensibility?
There's a big part that is due to the artistic nature, and I view the face as my canvas or a sculpture that I'm doing, and there's no size that fits all. It's more like delicate, simple, not simple, maybe delicate, gentle things that are done. And when I'm treating the face, where I'm treating, when I'm doing lasers, doing injectables, doing fillers, I feel like an artist and I'm doing sculpture. And I keep going back and looking from different angles and telling the patient to turn and twist and look up and down. So a big part of it is art and artistry, and that is how you achieve natural looks. If it's just one size fits all, it's not a balloon that we're filling.
Yeah, I have seen before and after photos on your website, quite impressive. But how do you manage patient expectation if someone wants divine transformations? You're not a magician, are you?
No, I'm not a magician, but a lot of the things we do and I do are like magic.
Yes.
And realistic expectations are very important, especially when it comes to things like, can you erase my scars completely? Can you wipe them out? And can you make me look like Angelina Jolie? Or
I would have that.
I have that, photo of an artist I found in a magazine. Of course, they're all airbrushed and photoshopped. Can you give me her lips? And you need to draw the line and sometimes say no, because this is not achievable. So it all boils down to patient selection, patient education, and knowing when to say no as much as you say yes.
I have to say that you have the smoothest, clearest skin I've ever seen in my life. People talk about my glowing skin. I'm pale in comparison. It's like sitting in front of the sun.
Thank you.
It can
You
actually be
have glowing
distracting.
skin.
Oh, bless you. Thank you. But it can be a little bit distracting while I'm thinking of questions. Wow. Like, do you think this is due to the treatments that you had in the past?
Yes, absolutely. So anything I do for my patients, I of course, I've started doing botulinum toxin when I was very young, and in my early 30s, mid 30s, I started doing dermal fillers. So they repair. I use all the active ingredients I told you about, and I tell my patients about. I've been wearing. I avoid the sun completely. I hate the sun. Cannot sit in the sun. So that has prevented me from getting wrinkles and laxity and sun damage in my 50s. And I do the procedures and lasers that I advise my patients to do.
Yeah, yeah. Dr. Injibar, where can we find you online, please?
So our website, the clinic is called Dermasurge, and our website is dermasurge.co.uk. All the numbers and all the information are on the website. We have Instagram, which is called Dermasurge London, and all the other channels that are available on the website.
Yeah, Dr. Injibar, I've always found dermatology a very challenging field. It's not straightforward by any stretch of the imagination. You break a leg, you fix a leg. You get a tumor, you extract the tumor. It's not as simple as that. But skin conditions are usually shrouded in mystery. When I was diagnosed with psoriasis, one of my professors said to me, in dermatology, you can walk into a maze for the rest of your life just trying to find the correct diagnosis. But you certainly know your way and you are at the top of your craft. To me, you strike an amazing balance between science and compassion.
Thank you.
And your warm character shows that perfectly well. The UK has won you. Okay, thank you so much. Thank you so much for coming to
It's a pleasure talking to you. Thank you.